Metro New York area of the Leukemia Lymphoma Society. I focus on Bronx County and Long Island, while my colleague Marie here on the screen focuses on the other 4 boroughs of New York City in her outreach efforts. Our goal is to connect those impacted by blood cancer with LLS as quickly as possible after a diagnosis. A primary way we do this is by building relationships with community organizations like PSS, as well as healthcare providers, to build awareness of and support for our programs and resources. We also work with a team of volunteers to implement education programs, like the one we have in the Bronx this coming March, on March 26th, which I'll mention later on in the presentation. For those of you not familiar with LLS, our mission is basically to cure blood cancer. We fund research to find life-saving treatments. We drive advocacy for policies to help people access those treatments. And of course, we provide patients and families with education, guidance, hope, and support. We are the largest nonprofit focused on blood cancer. Now, the Leukemia and Lymphoma Society name does not cover it all. As you can see on this slide, there are many different types of blood cancers, all of which are not covered in our name, but for which we can provide support. Blood cancer is more common than you might think. Approximately every 3 minutes, someone in the United States is diagnosed with blood cancer. To give you a sense of what the stats are locally, you can see on the slide that according to health.ny.gov, there are about 667 cases of blood cancer per year, and an average of 198 annual deaths in Bronx County alone. Those impacted could be our neighbors, family members, friends, or general community members. LLS has a wide range of free resources and programs for those dealing with a blood cancer diagnosis. I like to think of our programs in 3 buckets: emotional, educational, and financial. In terms of emotional support, we have support programs listed on our website, as well as a peer-to-peer program that connects patients or caregivers with a survivor of a similar experience. In terms of education, you can see here that we have things like podcasts, on-demand education programs, regularly updated blogs and webcasts, and free information booklets that you can have mailed right to your home. Our information is in English and in Spanish, as well as in some other languages. For financial support, we have programs that can help cover the cost of things like treatment copays, insurance premiums, travel to and from treatment. And then there are programs that can help you with non-medical costs, such as rent, utilities, and dependent care. I don't have time to go into detail about all of these resources, but you can find information on our website using the links that you see here on the screen. One of the services I do want to emphasize is what is truly at the heart of our patient services. We refer to it as the IRC. It is our Information Resource Center. The Information Resource Center is our team of master's level oncology nurses and social workers who connect with patients and caregivers one-on-one to answer questions, talk through concerns, and connect people to our resources, or if we don't have something that can help, to resources outside of LLS. The IRC can easily be reached by calling 800-955-4572 or using the email you see here on the screen. There's also a self-referral form that you can access by using your phone camera to scan the QR code, and someone will call you back from the IRC within a day or so. Our speaker today, in fact, is from the Information Resource Center. Through the Information Resource Center, patients can also access other individualized support services that we offer here at LLS that I have not yet mentioned, such as our free personalized nutrition consultations for patients with any type of cancer, not just blood cancer, or by accessing our clinical trial support center, which the IRC representatives can connect you to. That is a service of LLS that provides information about clinical trials for blood cancers and can connect people to clinical trials that might be appropriate for you. And all of those nurses are oncology nurses as well, who have a background working in clinical trials. And again, you can access this by calling the 800 number. Since this is Myeloma Awareness Month, I'd now like to share information about our Myeloma Link awareness campaign happening in 13 counties across the country, including right here in the Bronx. Before I go into information about the awareness campaign specifically, I want to share some critical information behind why we started this initiative. As you see here on your screen, Black Americans have more than twice the risk of developing myeloma when compared to white Americans. Black patients often face significant barriers to access timely, optimal treatment and care. This is particularly true for patients from low-income communities. Black patients are often diagnosed younger, likely to incur higher hospitalization costs, less likely to enter a clinical trial, and may have a more delayed time frame from diagnosis to treatment. Given this higher incidence rate among Black community members, Myeloma Link's goals include education about myeloma, its signs and symptoms, etc., and helping patients access optimal care and navigate the treatment landscape more effectively. Through work with a wide range of trusted partners within our Black communities, we aim to accomplish the goals you see here on this slide. A primary component and goal of this work is educating community members, as well as educating the primary care providers who treat them. You can learn more on our website at the link on this slide, lls.org/myelomalink. And now to bring it back to that program I mentioned at the very beginning of my presentation, we do have 2 programs on March 26th happening right here locally. Pre-registration is required, so everyone who is interested, please do register as soon as possible as we try to gather the numbers and prepare accordingly. The first program is in the morning on Tuesday, March 26th. If you go to the naeventscloud.com/MAR26/ or use your phone right now to take a picture or scan that QR code at the top of the screen, you will get access to the program website, which gives you information about the free parking, directions, the timeline for the program, and information about the program itself. It is called Myeloma in the Black Community, what it is and why there is hope after a diagnosis. You do not have to be diagnosed with a blood cancer to attend this program. It is, in fact, an education program meant to do some of what I said earlier, which is to educate the community about what this disease is, signs and symptoms, and what to do if you think you might be at risk. We will also have community organizations present, like PSS, at the event so that you can learn more about some resources available through other organizations in the Bronx community. There's also a program here on the bottom that you see here in Spanish that will be offered March 26th, once again, in the evening. You can attend virtually or in person at the Union Square location shown on your screen. We'll give you a reminder at the end of this presentation so that you can see this information once again. And now I'd like to introduce your guest speaker, Stephanie Attaway, who is also my colleague from the IRC. Stephanie was awarded her Bachelor of Social Work from Mississippi College and her Master of Social Work from the University of North Carolina at Pembroke. Stephanie further went on to obtain her OSWC, or a certification in oncology social work, while working in the pediatric oncology at Children's Hospital of New Orleans. Prior to her work in oncology, her background includes behavioral health and mental health, victims and children advocacy, including time as a family protection specialist. Stephanie's oncology experience includes direct practice and care for leukemia, lymphoma, and stem cell transplant patients and families. In addition to her excellent clinical skills, she has a passion for cancer advocacy at the local, state, and national level. Stephanie is an active member of the Association of Pediatric Oncology Social Workers and sits as the legal and advocacy chairperson on the APOSW board. She is also active in the Alliance for Childhood Cancer and sits on the planning committee for their annual action day that is held each spring in Washington, D.C. Stephanie, I will now pass you the virtual mic to tell us a little bit about blood cancers and their treatment.
Thank you so much, Andrea. And let me just share my screen. Okay, good morning and welcome to Blood Cancer 101. Thank you for having me come and speak with you today. The topics we will be covering today are what is blood cancer, the types of blood cancer treatments, the types of blood cancer, treatment options, clinical trials, and resources and support available to blood cancer patients, families, and caregivers. So, what is blood cancer? Blood cancers arise from the cells in our bodies that are responsible for the formation of blood and our immune system. Blood cancers commonly occur in your bone marrow where stem cells are located and mature, and are also found in lymph nodes where immune cells are located. A blood cancer occurs when the normal production of cells is interrupted and abnormal cells begin to grow. Blood cancers affect people of all ages, races, and genders. And you'll see here an image of blood and bone marrow, and this shows you how blood and stem cells are formed and how blood cancers can occur. Causes of blood cancer. Most blood cancers have no known cause. Most result from the damage to a gene and are usually acquired and rarely inherited. Possible risk factors for blood cancer may vary by disease, but include exposure to excessive doses of radiation, exposure to certain viruses and chemicals, and the use of certain cancer therapies. And here is an image of how blood cancers form in both the myeloid stem cells and lymphoid stem cells, which we'll get into later in the presentation. There is a low awareness of blood cancers, with nearly 80 and 90% of adults not associating lymphoma and myeloma as types of blood cancers, while most adults, 56%, do associate leukemia with blood cancer. Few adults associate lymphoma, myeloma, myelodysplastic syndromes, and myeloproliferative neoplasms with blood cancers, and we will be getting into all of those later in the presentation. And here is an image of the number of cases of each type of blood cancer in 2023, with lymphoma at 48%, leukemia at 32%, myeloma at 19%. The 5 types of blood cancer are leukemia, lymphoma, myeloma, myelodysplastic syndrome, and myeloproliferative neoplasms, with each type containing multiple subtypes. Blood cancers are diagnosed through a general medical history and physical examination, lab work, imaging tests, biopsies, and cancer molecular profiling. Cancer molecular profiling identifies DNA, RNA, and protein molecules associated with certain diseases. The types of tests used are flow cytometry, FISH, NGS, or next generation sequencing, and qPCR, or quantitative polymerase chain reaction. So, what is leukemia? In general, there are 4 major types of leukemias. Leukemias can be conceptualized as acute or chronic, and all beginning in the bone marrow, either in the myeloid stem cell line or the lymphoid stem cell line. The 4 main types are chronic lymphocytic leukemia, chronic myeloid leukemia, acute lymphoblastic leukemia, and acute myeloid leukemia. Chronic lymphocytic leukemia, or CLL, in some people is a long-term chronic illness that never needs treatment and is something they will die with rather than die from. Most people do eventually need treatment with CLL. Many don't need it at diagnosis though, so they are monitored under what doctors call a watch and wait period. Some people characterize this as watch and worry because it's hard to know that you have a cancer diagnosis but not do something to treat it. Doctors don't always treat it right away because the toxicities and risks of the treatment outweigh the risks of the damage that the leukemia is doing to the patients when they are first diagnosed. This is when the doctor would put the patient in a watch and wait protocol. The average age of a CLL diagnosis is about 70 years. There are many different subtypes that can be determined by the cytogenetic testing or molecular profiling that would suggest whether and how quickly treatment might be needed for chronic lymphocytic leukemia. Next, I will tell you about chronic myeloid leukemia, which does require treatment upon diagnosis to prevent it from becoming aggressive. But people who are taking the drugs that have been FDA approved over the last 20 years, such as tyrosine kinase inhibitors or TKIs, can usually live a normal lifespan if they take their medications as prescribed. Some patients are even able to stop those medications after several years with undetectable cancers. But of course, patients should never stop medication without the support of their doctor, who will monitor them more closely while they attempt that trial of not taking medications. Next, we talk about acute leukemias. These tend to be aggressive and need timely treatment. They're made up of blast cells. So the very first cells that the uncommitted stem cells, which are either lymphoid or myeloid blasts, can become cancerous in acute leukemias. Acute lymphoblastic leukemia, or ALL, is the most commonly diagnosed cancer in children and is also more often seen in adults over the age of 60. You can see ALL diagnosed at any age. Acute myeloid leukemia, or AML, is typically difficult to treat and cure, especially if it has high-risk cytogenetics, meaning the DNA of the actual cancer suggests that it's likely to recur or be difficult to treat. So for people who can tolerate it and have intermediate or high-risk cytogenetics, they usually receive a bone marrow transplant. AML is seen less often in children, but some children do get it, and it's often difficult to treat. Leukemias should receive cytogenetic analysis so that research into what the DNA of the leukemia is telling the doctors to determine the potential behavior, whether it's aggressive or slow growing, and whether it's likely to recur or not, to help the doctor decide which treatments are likely to be effective to treat each type of leukemia. Lymphoma is a blood cancer that develops in a single white blood cell called a lymphocyte. Convection-fighting lymphocytes are present in a vast system in our bodies called the lymphatic system. There are two major types of lymphoma: Hodgkin's lymphoma and non-Hodgkin lymphoma, which I will discuss more in a few moments. This is an image of the staging of lymphoma. While leukemia does not have stages, lymphomas do, and this slide depicts the different stages. As you can see, stage 1 means that somebody has just one small area of enlarged lymph nodes in one part of their body, above or below the diaphragm. In stage 2, they may have two different areas of enlarged lymph nodes, but both on the same side of the diaphragm, so either above or below. Stage 3 is diagnosed when there are enlarged lymph nodes, but both above and below the diaphragm. And stage 4 means that there's widespread disease. You can find the lymphoma in the bone marrow. You may find it in organs outside of the lymph nodes as well. But even if someone is diagnosed with stage 4 lymphoma, that does not mean that the cancer is not potentially curable or highly manageable for a long period of time. Stage 4 lymphomas can be cured, unlike solid organ tumors. And this is an image of the lymphoma incidence by gender in 2020. So you do see that Hodgkin's lymphoma had 8,480 cases, with the majority of those being male. Non-Hodgkin lymphoma had 77,240 cases, with the majority also being male. So Hodgkin's lymphoma. Hodgkin lymphomas are among the most common cancers to be diagnosed in young adults and are highly curable in that age range. Of course, you can be diagnosed with Hodgkin's lymphoma at just about any age. Most Hodgkin lymphoma diagnoses are of the typical classical type, and they present with Reed-Sternberg cells. Reed-Sternberg cells are large abnormal lymphocytes that may contain more than one nucleus. A few Hodgkin lymphomas are diagnosed as nodular lymphocytes, predominant type, which can be trickier to treat and cure. Non-Hodgkin's lymphomas are a very wide range of blood cancers that affect the B lymphocytes, T lymphocytes, or natural killer cells. Non-Hodgkin's lymphomas are usually characterized by their cell type and then their aggressiveness, whether they are aggressive or indolent, which means slow growing. 85% of all non-Hodgkin's lymphomas are B-cell lymphomas, and the other 15% are T-cell or NK cell lymphomas. The most common aggressive non-Hodgkin's lymphomas is diffuse large B-cell lymphoma. The most common indolent non-Hodgkin lymphoma is follicular lymphoma. Those two B-cell lymphomas represent about 65% to 70% of all non-Hodgkin's lymphomas, and the other 70 plus subtypes represent the other 30 to 35% of lymphomas. Next, I'm going to talk about myeloma, which is a cancer of the plasma cells. It can be a single tumor, which is called a plasmacytoma. It can be asymptomatic or slow growing. So some doctors call that smoldering myeloma, or it can be diffused throughout the body, and doctors call that multiple myeloma. How does multiple myeloma develop? It develops when a plasma cell is changed or mutated. Plasma cells are made from B lymphocytes, a type of white blood cells that is found in the bone marrow. Healthy plasma cells are part of the immune system and make proteins called antibodies, which help fight infection. The mutated plasma cell, the myeloma cell, multiplies, and if untreated, these cells continue to grow into the marrow. They crowd out the healthy plasma cells and the normal stem cells in the bone marrow that form the white blood cells, red blood cells, and platelets. If not treated, these cancerous cells can crowd out functioning white cells, and the immune system can't guard against infection effectively, secrete high levels of protein in the blood and urine, which can lead to kidney damage, build up in bone, causing it to weaken, which can lead to bone pain and fractures. And looking at myeloma patients' bones, sometimes doctors will describe bones as looking like they're Swiss cheese. If myeloma has really infiltrated the bone, it causes the bones to be weakened, and patients may be at a high risk for broken bones. If doctors find something wrong with a patient's blood count or their kidney or calcium labs, and then send them to a hematologist oncologist who will proceed with bone scans, bone marrow biopsy, and possibly a 24-hour urine collection to look for protein in the urine. These additional tests can help to determine whether the person has myeloma. Doctors look at what they call CRAB criteria to help them with the diagnosis. They are looking for increased calcium, renal/kidney failure, anemia, and bone lesions. Myeloma is typically diagnosed in older adults, people over the age of 60. Routine treatments for myeloma are generally tolerated well, even by older adults. Moving on to the myelodysplastic syndromes, these are sometimes called pre-leukemia by doctors. In general, these are diagnosed when there's 5 to 19% blasts found in the bone marrow. And then AML, or acute myeloid leukemia, is diagnosed when there's 20 or more % blasts in the bone marrow. Healthy people can have 0 to 4% blasts in their bone marrow, so it's possible to be completely healthy and still have a few blasts that may appear leukemic, but they're actually not. A healthy person can have some blasts. The risk factors for myelodysplastic syndromes tend to be that the person is older, usually over the age of 70, white, and male. We don't really know what the risks are for someone who gets an MDS diagnosis. However, some people can develop myelodysplastic syndromes after they've had treatments for breast cancer, other solid organ tumors like lung cancer or liver cancer. And those treatments can make people at risk for developing what they call secondary MDS due to the previous treatment. That can sometimes also progress and transform into acute myeloid leukemia. So it can be really important to pay attention and treat MDS, especially especially if it is resulting from previous cancer treatment. There are several subtypes of MDS. Some are more slow growing or indolent in nature and are managed by blood transfusions and careful monitoring. And others require immediate chemotherapy or even bone marrow transplant to manage or cure. It's possible to have no symptoms and have MDS. Some people just have low blood counts. Myeloproliferative neoplasms are types of blood cancer that begin with an abnormal mutation in a stem cell in the bone marrow. The change leads to an overproduction of any combination of white cells, red cells, and platelets. There are several types of MPNs. The three main traditional types are grouped together because of their shared features. These three are often referred to as classic MPNs or Philadelphia negative classical MPNs. They are polycythemia vera or PV, essential thrombocytopenia or ET, and myelofibrosis or MF. PV is characterized by the overproduction of red blood cells in the bone marrow. In many cases, the numbers of white blood cells and platelets also increase. These blood cells build up in the bone marrow and blood, causing the blood to thicken. ET is characterized by the overproduction of platelets in the bone marrow. Platelets stick together and form blood clots to slow or stop bleeding and to help heal wounds. When there are too many platelets in the bloodstream, they may clump together and make it difficult for the blood to flow. High numbers of platelets may lead to a thrombus, a blood clot that forms in a blood vessel. MF is characterized by the buildup of scar tissue called fibrosis in the bone marrow. As scar tissue increases, the bone marrow cannot make enough healthy blood cells. As a result, the spleen and liver may begin to produce blood cells, causing these organs to increase in size. Now, how is blood cancer treated? The treatment options for blood cancer are chemotherapy, radiation, targeted therapy, immunotherapy, cellular therapy, and clinical trials, as well as palliative care. The type of treatment offered to a patient is determined by the type of blood cancer the patient is diagnosed with, any possible genetic mutations seen in the blood cancer, and any comorbidities the patient may have. So, chemotherapy. Chemotherapy stops the growth of dividing cells and can be used in combination with other treatments, such as surgery or radiation. Chemotherapy can be given in many ways, such as by mouth, by IV, via a muscular injection, intrathecally, and intraperitoneal through the abdomen. Possible side effects of chemotherapy are fatigue, alopecia, neuropathy or confusion, mouth sores, nausea, diarrhea, cytopenias, which can lead to infection and bleeding, skin and nail changes, mood changes, and infertility or changes in libido. Radiation works by damaging the DNA of cancer cells so they cannot replicate. This can be used in combination with chemotherapy and surgery. Possible side effects for radiation are fatigue, localized skin changes, and then we have some specific side effects related to the area being treated. If If the lungs are receiving the radiation, you may experience fatigue, shortness of breath, and cough. If the brain is being treated, you may experience fatigue, hair loss, nausea, and vomiting. If your GI area is being treated, you may experience nausea, vomiting, diarrhea, abdominal pain, bladder, and infertility. If the head and neck are being treated, you may experience sore throat, dry mouth, taste alteration, and hair loss. Targeted therapies target the specific changes found in the cancer's DNA. The types of targeted therapies are monoclonal antibodies and cancer growth inhibitors such as TKNIs, proteasome inhibitors, PI13K inhibitors, HDAC inhibitors, and so on. The side effects for targeted therapy include diarrhea, liver abnormalities, skin and nail changes, high blood pressure, and alterations in blood clotting. Immunotherapy uses your own immune system to fight the cancer through monoclonal or bispecific antibodies. Possible side effects of immunotherapy include skin reactions, fever, chills, weakness and fatigue, blood pressure abnormalities, shortness of breath, nausea, vomiting, swelling or fluid retention, and organ inflammation, such as colitis, hepatitis, or pneumonitis. Cellular therapies are therapies that use your body's own defense system to fight cancer, such as stem cell transplant, tumor infiltrating lymphocytes, T cell receptor, and chimeric antigen receptors. A stem cell transplant allows a patient to receive high doses of chemotherapy to eradicate disease, but then recover normal hematopoietic cell function. The types of transplant are autologous, in which your own cells are used, or allogenic, in which donor cells are used. Chimeric antigen receptor therapy, or CAR T cell therapy. In this therapy, your T cells are removed from the patient, then re-engineered to produce chimeric antigen receptors, and then reinfused back into the patient, which then recognizes specific antigen or tumor cells. Possible side effects for CAR T cell therapy is cytokine release syndrome, or CRS, in which T cells naturally release cytokines. However, in CRS, there is a massive amount released, which causes fever and hypotension. Neurotoxicity is another possible side effect, in which you may see confusion, headache, seizure, and cerebral edema. And then B cell aplasia, in which normal B cells often killed by infused CAR T cells, since they express the same targets. Patients will go on to receive immunoglobulin therapy if they are experiencing B cell aplasia. Long-term or late effects for these treatments include pain, bone, muscle, and joint problems, fatigue and lack of stamina, heart problems, lung problems, lymphedema, peripheral neuropathy, premature menopause in women, cognitive deficits, sexual dysfunction, mental health effects, and financial concerns. Blood cancer survivors don't always have serious long-term or late effects of treatment. For those who do, these are some of the long-term effects that they may experience. Effects can range from mild to severe, and we do suggest talking with your doctor about any possible long-term effects that you may experience. Clinical trials of new drugs and treatments are essential in making progress against cancer. Today, people are living longer because of successful cancer treatments that that were the outcome of past clinical trials. Clinical trials are carefully controlled research studies conducted by doctors to improve the treatment options, increase survival rates, and improve the quality of life of cancer patients. Trials are available for all stages of the patient's cancer journey, from newly diagnosed to relapsed and refractory patients. Benefits of clinical trials include contributing to both the present and the future, financial access to new treatments, early access to new therapies, access to physicians with extensive knowledge and experience in your specific type of cancer, and close monitoring of your treatment. Risks of clinical trials include that the treatment may not be successful. Side effects of the treatment are unknown as it's a new treatment. In randomized trials, there is a chance that you will not receive the new treatment and instead will receive the current standard of care. And there may also be an increased time away from work, family, and home. Here we have the improved survival rates over the last several years of due to clinical trials. And as you can see, in all different types of blood cancers, the success rates have grown drastically from 1975 until 2018. Now, I just want to remind you all of the Myeloma in the Black Community event that will be happening on March 26th, as well as the event that will be happening later in the evening on the 26th from 5:30 to 7:30 at Union Square. And I hope that you will all participate and learn a little more about myeloma. And now I'm going to turn it over to Robert Foltz Morrison with our LLS Myeloma Link. He is one of our Myeloma Link ambassadors.
Good evening, or good evening, good afternoon. I'm glad to be with you. I'm Robert Foltz Morrison, 67-year-old retired Presbyterian minister and a blood cancer survivor. I wanted to share with you three things. The first is how I came to be diagnosed with a blood cancer. The second is the treatment plan that I entered into. And the third thing are other factors, not always illuminated, that contributed to my getting better with a blood cancer. So the first thing I want to say is, I don't know if any of you have ever had a persistent pain in your body. I'm sure all of us have, but I had this persistent pain during the pandemic in 2021. And so I did what I normally would do, would be to call up my primary care physician and ask for some physical therapy appointments. I did that once. First time didn't go well. I did it again. Second time didn't go well. Both ending with me being in excruciating back pain. It was thought the best next thing to do would be to do an X-ray. The X-ray confirmed that there were fractures in the vertebrae in my spine. I had had no known falls. I was not in any terrible accident. And so my primary care doctor said, let me run a specialized blood test. This blood test is not the blood test that you're normally given when you go for those annual physical exams. He was looking for more than the usual things. And sure enough, something enough turned up that he said, I believe you have the blood cancer known as myeloma, and that you should see a cancer specialist. As has already been described to you, myeloma is this cancer of the blood plasma cells in our blood, and these white blood cells that often are supposed to fight infection undergo genetic mutations from myeloma, which we don't know what the cause is. And they're more prevalent, as has been said, in older adults, twice as likely members of our Black community. But what these mutated cells do is they crowd out space in the bone marrow, and you can feel those things already named, like anemia, fatigue, bone pain or fractures, kidney dysfunction, abnormal calcium and protein levels in blood tests. And for me, it was obvious with 7 damaged vertebrae in my spine, which was the source of the acute pain I was feeling. So the first thing that my doctor, my oncologist, said needed to be done was to repair the spine. And so I had spinal surgery, and it was amazing the results of that surgery in light of how much pain I no longer experienced. It was incredible, and I was glad we undertook it. The next thing was to really fight the myeloma that was in my body, which involved 6 months of once a week outpatient chemotherapy infusion. That's through IVs. The next thing that happened after those 6 months, this is 3 weeks of an infusion, 1 week off, 3 weeks on, 1 week off for 6 months. And then afterwards, I had a bone marrow biopsy to determine, is there any myeloma left in my bone marrow? And there was just a little bit. So I chose to go through what's called an autologous stem cell transplant. My own stem cells were harvested from my body, and 10 days later, I went into the hospital where a powerful chemotherapy, Malphalon, was induced into my body, literally just wiping out anything that looked irregular. And then the very next day, those stem cells that had been harvested were reintroduced in my body to the effect that they would produce healthy stem cells going forward. Then the 2 weeks I was in the hospital, they had 2 more injections of those stem cells to again pump my body up with having healthy stem cells. 2 weeks later, I was dismissed from the hospital, sent home, monitored carefully from home, and 2 months later, I was back to work, God willing, to do the work that I had been doing before. Now, after the stem cell transplant, the doctor wanted to make sure that it was on a maintenance schedule to prevent any myeloma from relapsing, reoccurring in my body. And so the primary specialty drug that I was given, as many are, was Revlimid, or its genetic name is lenalidomide. It was incredibly helpful to me returning to an active life, even though the reintroduction of vaccinations in my body had to wait a year because, as you see, I was immunocompromised by Malphalon, which wiped out some of my vaccinations as well. So I had to watch my social life and how much contact I had with others. But a year later, I was revaccinated and again, continuing on with the maintenance drug. What I'd like to share with you also is some other factors that contributed to my getting better. One of it is, how do you face what's ahead? Do you face it with the kind of attitude that, well, I can or I will do this because I need to take care of myself? It's real important that you come to that point or have others help you come to that point. Another factor that helped me was having doctors who listen to you and are attentive to your condition and who you can trust with what you have to do ahead. And if you don't feel like your doctor's listening or isn't attentive to your conditioning or not trying other remedies like checking for myeloma, then you might want to get a second opinion or check with others as an LLS. Where can I find an oncologist that might be able to help me if I do have myeloma? An important piece also PSS emphasizes is having a supportive caretaker. That was my wife, who journeyed through much of what I was going through with me and was there throughout, helping me to make the changes that I needed to make. Another factor is learning about my blood cancer, going to webinars online, going to conferences, doing my own reading. So I began to understand, but not just going online and looking at anything, because some of those can be quite frightening, but even using LLS, which has an incredible encyclopedia of resources you can read, as well as personalized support by calling people. The other thing that I did throughout my journey and continue to do is I journal. I journal a lot. So I journaled about what I was thinking, what I was feeling as I was going through this, even writing poetic reflections to help me cope, and then talking to my primary care doctor and my oncologist about these things I was thinking and feeling to make sure we were all on the same page in terms of the healing that we all sought. But lastly, I'd like to say there's also some routines that are helpful to keep up with. One is meditation or prayerful calming moments, because there will be moments of anxiety. And in such moments, it's important to nurture a positive attitude as you're going through this. Another thing is exercising. This can be home exercises, it can be outpatient exercises that your doctor asks. It can be sitting yoga, and also importance of taking walks. And if you're able to be outside, or at least from inside to look outside, and even imagine yourself getting well. Another factor is making changes in diet. I made changes that were following nutritional and restorative guidelines that I've been able to keep for the last 3 years or so, that have really helped me to do much better. And then the final thing I'd like to share with you is that, as was shared long ago in this presentation, there is something called a Leukemia Lymphoma Society chat group online every Monday evening with other persons who have myeloma to talk about our experiences. And so I participate in that, and we share treatment options that Stephanie has already gone over with you. I do want to say that for those of you who have community events in community centers or in faith or church events, or setting up health fairs, we in LLS and myself are available to do presentations and to talk more personally with those who come. So I'd like to thank you for the opportunity to share my journey, and I'll turn it back over to PSS. Thank you.
Thank you very much, Robert. That was very moving and informative. The whole presentation was incredibly informative. So if there's anybody with any questions, now's your time to put them in the chat or the Q&A. It looks like we have a quiet group today, but I do have a question or two. So one of the things that really struck me in this presentation was you're talking about the higher rate of blood cancer among Blacks, and yet at the same time you're saying you don't know why. That just seems very odd. Can you add anything more to that?
I would just say, Stephanie, I would resort to you on this, but I would say that there, even as there's a myeloma podcast actually that just came out in collaboration with Montefiore with a myeloma expert. So as early as this week, I have just recently heard from her. There's still no understanding clearly why that is. There is very much interest in that. There are researchers looking to see if it is genetically related or environmentally related, or just what could possibly be the reasons for these drastic increases in racial disparities when it comes to myeloma. But as of now, my understanding is there is just not an understanding as of yet. Stephanie, is that yours as well?
That is my understanding as well. And I would say that to me, that is just more reason that we need more funding for research so that we can get to the bottom of questions like that. Because unfortunately, all we know at this point is that they are at a higher risk. We don't know why.
Okay, thank you.
Could I chime in? Could I chime in? One of the things that was part of my story is that it wasn't thought that the bone pain should be examined earlier. And then when the x-rays came up, it's there. So part of it is also the diagnosis and the options, and also being true in talking to your doctor. And there could be insurance issues that are driving people away from it's going to be too costly, or work issues that say, I can't take a day off. I've heard that often, and I don't want to go to the doctor. So these are some factors across the board that can be contributing to why people don't get the care that they need.
Interesting. I see we do have a question there. Where can I get information about essential thrombocytosis cytopenia, if I'm pronouncing that correctly?
Yes, essential thrombocytopenia. It's a difficult word to say. But you can reach out to the Information Resource Center. We have information specialists like myself who are available from 9 a.m. to 9 p.m. every day and can answer any questions that you might have. We also have booklets available both on our website and that can be ordered so that you have a hard copy at your home as well.
Okay, thank you. One more question, comment from me. So I found the presentation actually rather hopeful, both from Robert's personal experience and from everything you're saying. I guess there's no good cancer to get, but it sounds like if you did get blood cancer, your chances might be better. So that's my comment. My question is, you mentioned clinical trials. Are the fact that we're in New York, is that something that's more of an option for people?
So I will say that New York having many different hospitals that do research is promising. There are a lot of clinical trials in those hospitals, but there are also clinical trials being held around the country. And our clinical trial support center, honestly, to me, is just one of the most amazing teams as part of LLS because they have their own database of all of the available clinical trials for blood cancer patients. And what they do is they gather the information from the patient of where they're located, how far they're able to travel, and they pull up exactly what clinical trials are available to them within those parameters. And then they give it back to them in this beautiful document that they can then take to their doctors who will ultimately be the ones to put in the referral to the clinical trial.
Okay, very good. It sounds like if anyone were diagnosed with any kind of blood cancer, it'd be worth their while to contact the Lymphoma and Leukemia Society, just because of the kind of information and other resources that you have.
Yes, I highly recommend that anyone who is diagnosed with a blood cancer or has a family member diagnosed with a blood cancer reaches out to us because a lot of times most people, like I said in one of my early slides, don't even associate most blood cancers as being a blood cancer. And we have a lot of information that can help people understand their diagnosis, their treatment options, and just have a slew of supportive services available. And a lot of times people are just so overwhelmed when they're talking to the doctor and being given the information that they're not able to take it all in. And speaking to someone that is using more layman terms with them really puts them at ease.
Okay, well, seeing there's no more questions, I want to thank our presenters again for this enlightening and very informative and helpful presentation. And with that, I'm going to turn it over to our own Jaylene Irizarry to talk a little bit about one of our programs.
Thanks for having us.
Thank you so much. So hi, everyone. My name is Jaylene Irizarry. I'm a care consultant at the PSS Circle of Care team. We're a caregivers program that offers free supportive services to caregivers who are caring for a loved one who is chronically ill, suffering from memory loss or dementia. These services include counseling, support groups, educational trainings, supplemental items, respite care, advocacy, and assistance with long-term care planning. If you'd like to find out more about our program, you can always give us a call at 866-665-1713. Again, 866-665-1713, or you can visit our website at pssusa.org. Thank you everyone so much for your time. And I will also share that contact information in the chat box.
Thank you, Jaylene. Yes, you can look on our website. I do recommend you continue to look at our website for upcoming events as well as obviously this one that we just had. So I want to thank our presenters again. And we will be sending out some information about the presentation today to our attendees. So if you do have questions that come up afterwards, hopefully some of this information will be helpful, and we'll have contact information for our presenters. With that, we're going to end the presentation. Thanks again, everybody. Take care and be well.